Okay, so we'll look at the groin. The groin is also known as the inguinal region. It's a region or the area that is found between the anterior abdominal wall and the thigh. The anterior abdominal wall and the thigh, that region is what is known as the groin. So in this area, the abdominal wall is thickened. Okay, there's going to be a peritoneal sac or diverticulum, sometimes with or without abdominal content, can be able to come out through this region between the anterior abdominal wall and the thigh, and it's not going to be known as a hernia. So because it is in this region, it's in the inguinal region, it's known as the inguinal hernia, which can occur in both types of sex. So the inherent weakness in the anterior abdominal wall in the groin is caused by changes that occur during the development of the gonads. Before the descent of the testes, you know that when the testes and the ovaries are developing, they are going to develop on top, like in the abdominal region. So when these guys develop in the abdominal region, they'll start now going down. So for them to be able to reach down in that region, they have to be able to pass through this region. Okay. So before the descent of the testes and the ovaries from their initial position high in the posterior abdominal wall, a peritoneal outpocketing or outpouching, which is known as the processus vaginalis, is going to form protruding, and it will be able to pass or protrude through the various layers of the anterior abdominal wall. Now, the anterior abdominal wall is going to have the skin, the muscles, and fascias. So, processus vaginalis is going to be able to pass through all these layers, and then each one of those layers becomes a covering. So, the layers of the anterior abdominal wall, you first have the skin. You are going to have superficial fascia. Now, the superficial fascia is going to have two layers. You have got the campus fascia, which is fatty, and the scampus fascia, which is membranous. And then after that, you are going to have now the deep fascia, and then you are going to have the muscles. You are going to have the ones which are transverse. You are going to have, those different layers of the muscles. Now, what is going to happen is you are going to have the internal oblique, the external oblique, and the transversus abdominis. All these layers of muscles and fascias will become the layers which will be able to cover the processus vaginalis, which is an outpocketing as it gets to move down from the upper portion where it is. So the transversalis fascia, because when you look at the layers of the abdomen, the transversalis fascia is the innermost fascia here. So it's going to form the deepest covering because the one which is most inside. The second layer is going to be formed by muscles, which is the internal oblique, a covering which is from the transversus abdominis muscle, is not going to be acquired. So I should have been drawing, but I don't have what to use to draw. What is happening is this. The muscles which are on the abdomen, remember we're having the processus vaginalis, which is just an outpocketing, which is moving and then passing going to the groin. Transversalis fascia is going to form a layer of it. Internal oblique. After the internal oblique, we're going to have the transversus abdominis, and then we have got the external oblique. Actually, we have got external oblique, internal oblique, and then the transversus abdominis, different layers like that. Now, what is happening here is that transversus abdominis muscle. Let me first show this so that you can see how they are. Okay, here are the layers. You have got external oblique, which is the outermost layer of the muscles. internal oblique, and then the transversus abdominis. You can see it's the one which is more inside. So you have got something, an outpocketing. Imagine something grows and then it starts to push against the transversus abdominis, and then it will push the internal oblique, push it through the internal oblique, and then push it through the external oblique. And it's not breaking, it's not passing through these, but it's more forming. They become coverings as it gets to move like that. Okay. Now the transversus abdominis muscle will not form a covering because the processus vaginalis is going to pass under the arching fibers of the abdominal wall muscle. The reason as to why the transversus abdominis is not forming any covering of the transversus processus vaginalis is because it's passing below where the muscles are actually turning, where the transversus abdominis is turning, because it will not continue going down to reach the bottom. There will be a point where it has to reach as you go down. So that is where this is passing. Okay, and then its most superficial covering, the most superficial covering of the processus vaginalis is going to be that of the aponeurosis of the external oblique. It's not the external oblique muscle, but the aponeurosis. So where the muscle, the external oblique muscle is ending, that's where this aponeurosis will be able to, that's where this processus vaginalis will be able to pass. So the processus vaginalis is transformed into, it becomes a tube with different coverings, and that will form the basic structure of the inguinal canal. The inguinal canal is going to be on the left side and also on the right side. So the process, this same processus vaginalis, the process of the development of this same inguinal canal is going to happen. Actually, before that, the next thing that is going to happen after you have formed this inguinal canal, the final event in this development is the descent of the test. So remember, this is a canal, it's an opening, it's a tube. Now you're going to have the testis now being able to pass into this tube, okay? Or even the ovaries will be able to pass this tube. So the testis will pass this tube and go into the perineum. The ovaries will be able to pass and then go into the pelvic cavity. The process of the movement of these guys moving all the way from the top going into either the pelvis or the perineum is going to depend on the gubernaculum. So it will be more understood as we talk about the embryology formation of this region. The This is the reproductive system. So the gubernaculum is the one which is directing the descent or the movement down of these structures that we've just mentioned here. Okay. So as the testes move down in men, they are going to be accompanied by their blood vessels, their ducts, and also their nerves. So everything which was going to the testis will follow the testis as the testis goes down all the way from the abdomen, from the posterior abdominal up, all the way into the perineum. Okay. So testicular descent completes the formation of the spermatic cord. When the testis move down via the same processus vaginalis, then you would have completed the formation of the spermatic cord. In women, the ovaries are going to descend and then they are going to be able to go into the pelvic cavity. And there they are going to be able to develop with associated structures like the uterus. So the only remaining structure passing through the inguinal canal is going to be the round ligament of the uterus in females. And the round ligament of the uterus is actually the remnant of the gubernaculum, which is the same structure, so it's directing the movement of these parts. So what are we saying? In women, the ovaries are going to descend into the pelvic cavity and become associated with the developing uterus. It goes into the pelvic cavity instead of going into the perineum. So because of that, the only thing that remains passing through this same inguinal canal will be the round ligament, the one which was supposed to be directing the testis where to pass. Because in females there are no testes, so this would be the only thing that would be there. Okay. So later on, the processus vaginalis is supposed to be to obliterate. It's supposed to cease. It's supposed to vanish like that. If it does not occur, or if it is incomplete, then there's going to be a potential weakness in the anterior abdominal. Remember, this is supposed to be like something that moved through a canal, okay, to be able to allow the testis to pass. So if it does not vanish, it leaves that weakness in the abdominal wall, and that is where contents from the abdomen, like the intestines, can actually move from the abdomen, and then they are going to come outside, and that forms the inguinal hernia. In males, only approximate the only proximal region of the processus vaginalis is going to actually uh, obliterate. The distal ends will enclose most of the testis and the scrotum. In other words, the cavity of the tunica vaginalis in men forms an extension of the developing peritoneal cavity. Now, if I mention also the tunica vaginalis, this is just the covering, one of the coverings of the scrotum. So one of the coverings of the testis, I mean, which is part of the scrotum, will be an extension of the developing peritoneum. Remember this thing we are saying, the processus vaginalis came actually from the from the abdomen, and it went like that. So diagrammatically, to make more sense, you can see here you have got, so the regions of the anterior abdominal, you have got first the skin, you are going to have your external oblique in before the muscles, of course, are going to have the superficial fascia, the deep fascia, and then external oblique, internal oblique, transversus abdominis, and then you are going to have extraperitoneal fascia. This is the fascia that is just immediately before the parietal peritoneum. The parietal peritoneum is the peritoneum that is lining these organs. After the parietal peritoneum, then you are going to have visceral peritoneum, which is lining the actual viscera. So look, you're having the testes which are moving out, but before the testes, you can see the gubernaculum, which is directing the ascent or the passing of these testes. And you can see for the transversalis fascia at this point is to not form any covering here, because that's where more like it gets to 10. And then the all layers, they are still there, the internal oblique, the transversus abdominis, the external oblique. And then the testis will continue to move down. You can see this outpocketing which is coming from the abdominal wall, which is called the processus vaginalis. So this is where now the testis will be able to come and be able to pass also there. Okay. Now this same region, which it doesn't really pass here, but it's just more a space there, which is making this region to be more also soft or tender, and then the testis to be able to pass. If you can see, this region remains delicate. So meaning that if it does not obliterate, if it does not vanish, contents can actually come and the intestines can come and be able to pass here. They'll end up in the scrotum or just anywhere in the thigh. And so that leaves it remains as a weak spot. So talk about the same inguinal canal. The inguinal canal is a passage that extends in a downward and medial direction. Down, it goes down but goes more medially. Okay, just above and parallel to the lower half of the inguinal ligament. I just wish you had watched the previous class, because we had described the inguinal ligament and these other things. So it is going to begin at the deep inguinal ring and continue approximately 4 centimeters, and then it will go into the superficial inguinal ring. Deep inguinal ring to the superficial inguinal ring. What are the contents? What things pass through this inguinal canal? A genital branch of the genitofemoral nerve. Not the genitofemoral nerve, but genital branch of the genitofemoral, because this nerve has got the genital branch and then the femoral branch, but specifically the genital branch. You also have the spermatic cord. Spermatic cord has going to also have a lot of contents, we shall see. In women, you are going to have the round ligament of the uterus or ligamentum teres of the uterus. In men, spermatic cord. So apart from these three which we've mentioned, the genital branch of the genitofemoral, spermatic cord in men or round ligament in women, you also have the ilioinguinal nerve, okay, that will be able to pass and exit through, which will be able to exit through the superficial inguinal ring. The deep inguinal ring, I think this will make sense if you see the structure. So this one, you can see this is the pelvic bone, got the anterior superior iliac spine here, and then in front here you have got the anterior inferior. It's actually, it will not even attach there, it is attaching somewhere at the end, somewhere where there is a pubic symphysis here. So this is the inguinal ligament. Inguinal ligament is formed from the aponeurosis of the external oblique. Look at the external oblique. This is the external oblique muscle here. As it goes at the end here, it's going to be able to turn and form this ligament, which is known as the inguinal ligament. Now, the spermatic or the inguinal canal is actually starting from here. At this point, this is where you're seeing the deep inguinal ring. The superficial inguinal ring will be somewhere down here. This is on this other diagram, you can see the deep inguinal ring is here. Superficial inguinal ring is somewhere down here. So the spermatic cord is coming all the way from the inside and then passing, it penetrates, it comes out, and then it goes into the perineum like that. So the deep inguinal ring is also called the internal inguinal ring because it's more inside in comparison to the superficial inguinal ring. This one, it is at a point midway between the anterior superior iliac spine and the pubic symphysis. Please, this is important. The deep inguinal ring is on the middle point between the anterior superior iliac spine and the pubic symphysis. Here, this is the anterior superior iliac spine. This is the pubic symphysis on the middle point. This is where you're going to be able to find this ring. It is not on the middle of the inguinal ligament. Okay, it's not on the middle of the inguinal ligament, but on the middle of these 2 points we've mentioned. It is just above the inguinal ligament also, and immediately lateral to the inferior epigastric vessels. And when it comes to anatomy, they really love uh, relations of structures. Relations is very, very important. Look at this. These are what we are calling as the epigastric vessels. Okay, you have got the epigastric artery, which is more lateral, and then you have got the epigastric vein. And we are saying this one will just pass immediately lateral to the inferior epigastric vessels, just immediately lateral. Okay, somewhere there, that is where the ring is. Please take note of that. Sometimes, okay, although sometimes referred to as a defect or opening in the transversalis fascia, it is the beginning of the tubular invagination of the transversalis fascia that forms one of the coverings. So this same deep inguinal ring we are talking about, one of the coverings, the internal spermatic fascia of the spermatic cord in men and the round ligament of the uterus in women. I'll describe that statement well. I know you might not get it very much now. Superficial inguinal ring is going to be much down. It is also known as external inguinal ring because it is down. Okay. And this one is triangular. It's a triangular opening and it is in the aponeurosis of the external oblique. Just take note of that. Its apex is pointed superolaterally, meaning it is up lateral. Okay. This is the one. Its apex is somewhere here on top and lateral. This is the superficial inguinal ring. The deep inguinal ring is more inside. Some what you need to understand more are the contents and the boundaries. Contents and boundaries. Now, when you talk about the boundaries of this inguinal canal, this is where you can have a lot of questions. You have the anterior wall, you have got the posterior wall, you are going to have, okay, let me use, I think I had a diagram here. Okay, you are going to have the roof, which is the top part here, which is also known as the superior wall on top. There's a nice mnemonic here you can use, MOT. The roof is formed by the EMS muscles. The anterior wall A is formed by the aponeurosis. And then the floor which is going to be formed by ligaments. Then the posterior wall is going to be formed by the transversalis fascia and these others. Now let's understand this. So the roof of the inguinal canal is formed by the internal oblique muscle and transversus abdominis muscle. So these two muscles, the muscles are actually just supposed to be three: external oblique, internal oblique, and transversus abdominis. So just remove the external oblique. External oblique is the outermost. It does not form the roof. Okay, just these two muscles. Anterior wall in front, that's where we're going to have the external oblique, but not the muscle, but the aponeurosis of the external oblique and also the aponeurosis of the internal oblique. These two muscles just follow themselves. So also the aponeurosis which are just next to each other. Those are the ones which will be in front as the anterior wall. The floor will be formed by the inguinal ligament and the lacunar ligament. The lacunar ligament is a ligament that comes out of the inguinal ligament just at the end. I have a picture. So this is the inguinal ligament, this one. At the end of the inguinal ligament, that is where we're going to have the lacunar ligament. And that one is the one which is forming the floor. You can see that is the inguinal ligament is at the bottom of the inguinal canal. That is why it's forming the floor. And then posteriorly, what is going to happen is this: that transversalis fascia and the conjoint tendon. The conjoint tendon will actually be these same ones which are on top. So these muscles which are on top, the internal oblique muscle and the transversus abdominis muscle, what to happen is that they are going to cave and go to the posterior side. When they are going to cave, go to the posterior side from the top, and when they go to the posterior, they are no longer muscles, but they will form a tendon which is called the conjoint tendon or the fax inguinalis. They can bring that name, one or that. Okay, so the transversalis fascia and the fax inguinalis or the conjoint tendon will form the posterior wall. So we had already mentioned to say the contents of the spermatic cord. You are going to have blood vessels, nerves, and other structures. For the blood vessels which will pass through the spermatic cord, you are going to have the pampiniform plexus or veins, which are also known as testicular veins. The artery to the ductus deferens, okay, and this one comes from the inferior vesical artery. Please just take note of that. I think I've seen a question on that. The artery that goes to the ductus deferens comes from the inferior vesical artery, and the inferior vesical artery comes from the internal iliac artery. You also have the cremasteric artery and vein. The cremasteric artery and the cremasteric vein, these guys will come from the inferior epigastric arteries. You also have the testicular artery, which comes from the abdominal aorta. Nerves which pass through the spermatic cord include the genital branch of the genitofemoral nerve and also some sympathetic and visceral nerves. Other structures which will pass through include the most important, which is the ductus deferens or the vas deferens, lymphatics, lymphatics of the testis and the epididymis, and also the remnant of the processus vaginalis. Remember we said the processus vaginalis in men, only the proximal part will be able to disappear, the distal part still remains. Okay, so this is what we are talking about. If you see the testicular vein, let me start with the artery. Testicular artery, the left testicular artery and the right testicular artery, both of them come from the abdominal aorta, right? That is what we are saying. If you look at the cremasteric artery, this artery here, look at where it is coming from. What happens at the abdominal aorta when it reaches L4, somewhere L4, L5, to be able to branch into the common iliac artery. Common iliac artery also branch into the internal iliac and the external iliac. You can see the external iliac now, that is where the cremasteric artery is coming from. But specifically from the cremasteric artery, you are going to have the inferior epigastric artery. Because what happens is this, the external iliac will give the inferior epigastric. Epigastric, these arteries will go and supply the anterior abdominal wall and there's some structures inside. From the inferior epigastric artery and vein, that is where the cremasteric artery will come from. Just take note of that. Cremasteric artery comes from the inferior epigastric, and the inferior epigastric vessels come from the external iliac artery. And then the other artery that we talked about here, apart from the testicular artery and the cremasteric artery, we also have the artery to ductus deferens. If you can see, the artery to ductus deferens is coming from the internal iliac, which is here. The artery to ductus deferens is coming from the internal iliac, but it will not come direct from the internal iliac. It will come from actually the inferior vesicle. Okay? The internal iliac will give the inferior vesicle artery, and that inferior vesicle artery will be now the one where the the artery to ductus deferens will be able to come out. These are questions they like asking. Just take note of that. Now for the veins, the testicular veins are different from the testicular arteries. The right testicular veins will take blood direct into the inferior vena cava, but the left testicular vein will take its blood to the left renal vein, and then it will go to the inferior vena cava. This is also one of the important questions they can ask you at this point. Are we okay here? Okay. So the coverings now, the coverings of the spermatic cord. Spermatic cord is going to have three major coverings: internal spermatic fascia, cremasteric fascia, and external spermatic fascia. The internal spermatic fascia is coming from the transversalis fascia. Remember, it's internal. Look at this structure. Where is the transversalis fascia? Look at this where I'm pointing. The one in green, that is the transversalis fascia. Transversalis fascia will continue and go and round this spermatic cord, and it becomes the internal spermatic fascia. The next covering will be the cremasteric fascia, which comes from the internal oblique muscle. The internal oblique, if you can see, internal oblique muscle is here. It is going to continue down and then it will become the cremasteric fascia, which you can see here. Then the last covering is the external spermatic fascia. The external spermatic fascia is coming from the aponeurosis of the external oblique muscle, not the muscle itself, but from the aponeurosis. This is the aponeurosis of the external oblique muscle. When it gets to go like that, it becomes the external spermatic fascia. And then inside you are going to also have the parietal layer of the tunica. You are going to have the tunica vaginalis. Tunica vaginalis is going to have the parietal and the visceral layer. Visceral layer is always the layer which is closest to the structure that you're talking about, and then the parietal. So the space between, the potential space between, is called the cavity of the tunica vaginalis. This is what we are talking about. You can see we have got the spermatic cord inside here, and the spermatic cord has got all these structures that you can see. Testicular artery, you have got the pampiniform plexus of veins. Now on the layers, you are going to have the, okay, inside the spermatic cord you also have the ductus deferens there. You can see this one. You have the testis also down there, the epididymis. Okay. Now the muscle, cremasteric muscle. This is the muscle that will be able to surround the testis. That's the cremasteric muscle. So that one we've said that the cremasteric artery is actually going to this muscle which surrounds the the testis. Okay, you also have the skin there, and then you have got the fascia of the spermatic cord, which is this fascia there, and then superficial fascia of the penis. This is the penis there, deep fascia of the penis. Okay, I just wanted us to see that. In a female, you not have the spermatic cord. Instead, you are going to have the round ligament of the uterus to replace the spermatic cord. So there are some formations which are called varicocele which can be formed. Now, if you look at the pampiniform plexus of veins, when they dilate, that is what we call a varicocele. It's a dilated tortuous pampiniform plexus. If you can see, look at here, the pampiniform plexus of veins on the left are more dilated and more tortuous than on the right. The reason is because on the left, there are three major reasons as to why on the left, the pampiniform plexus of veins are more dilated than on the right. They form varicoceles. On the left, if you can see, you have got blood which is coming from the left kidney. This blood can actually end up going down here, and it will go down at high pressure. So for this blood coming from the left pampiniform plexus of veins to be able to go up, it needs to go at a high pressure. So for it to go at a high pressure, it need to be dilated and tortuous. Okay, that is how it will be able to manage to ascend. And then the other thing is that these varices, these torsion dilated parts will be seen. The dilated pampiniform plexus of veins will be seen because these veins actually don't have effective valves. They don't have valves, absence of valves. So because of that, they need to have that dilation and tortuousness to be able to push blood up. And also on the left, it is more tortuous than on the right, because on the left you have got actually the sigmoid colon. This sigmoid colon will be able to compress the left testicular vein. Because the left testicular vein is being compressed this side, for it to be able to push blood up, you need much strength than on the right. That is why it is more tortuous. So these varicoceles will be able to increase the temperature of the testis, and they can actually lead to infertility because of low sperm production. Is this okay? Okay. The lymphatics of this region, of this same region we are talking about, the groin. So from the testis, you are going to have the para-aortic lymph nodes. Okay. The testis will be able to take their lymph to the para-aortic lymph nodes. You can see these are just parallel to the aorta, the para-aortic lymph nodes. And then the scrotum will be able to take their lymph to the superficial inguinal lymph nodes, or the superficial group of inguinal lymph nodes there. So that is how these are going to be able to drain their lymph. Including also the skin of the scrotum, the skin of epididymis will also go to the superficial inguinal lymph nodes, but the testis will go to the para-aortic lymph nodes. So this is just showing the round ligament of the uterus that we've already talked about. You can see the round ligament of the uterus, it goes like it is passing through all these layers, penetrating and then coming. The round ligament to actually end up going, this is supposed to be going to the uterus. So you're saying round ligament of the uterus. But then in this region, look at this. In the region we're supposed to be having the spermatic cord, you don't have a spermatic cord in females. You are going to have the genital branch of the genitofemoral nerve. Okay, it will be able to pass and look at where it goes. It will be able to supply this skin. That is why the skin that is on the medial side or the thighs is more sensitive. If it is touched, it causes that arousal because of this same nerve here, the genital branch or the genitofemoral nerve. Okay. So the round ligament of the uterus is the long distal part of the original gubernaculum in the fetus, which came from the ovaries to the labioscrotal swelling. Labioscrotal swelling, this is what ends up to form the labia majora and the scrotum. So from the attachment to the uterus, the round ligament of the uterus continues and it will go to the ovary as a ligament of the ovaries. And this one is going to develop from the short proximal end of the gubernaculum, which is the ligament of the ovary develops from the short proximal end. The distal end, which is long, gives the round ligament of the uterus. Okay. So you can actually tell where these guys are located by just observing. Like the superficial inguinal ring in men, when you can, for men we can actually feel we can feel the spermatic cord. So when you feel this, when you follow the spermatic cord as it goes to the abdomen, just superiorly to the lower abdominal wall, just near the lower abdominal wall here, okay, just somewhere here. That is where we're going to have the superficial inguinal ring. And then in women, to tell where the superficial inguinal ring is, it can be palpated, and the ring is superior and lateral to the pubic tubercle, which can be palpated, the pubic tubercle. So the pubic tubercle is going to be here, somewhere here, you are going to have the pubic symphysis. Okay. So just somewhere, look at where it is, superficial inguinal ring, just here. It's very much near where the pubic tubercle is. Pubic tubercle, just before you can have the pubic symphysis. Okay, that is where we're going to have the pubic tubercle. That is where we're going to be able to find the superficial inguinal ring. You can actually palpate it, you can feel it as you press the lower end of the abdomen there. And that is going to just be superior and lateral to the pubic tubercle. So a bit up when you feel that prominence, and laterally. The deep inguinal ring is going to lie superior to the inguinal ligament, midway between the anterior superior iliac spine and the pubic symphysis. So the pulse of the femoral artery can be felt in the same position but below the inguinal ligament. The same midway, you can also feel the pulse of the femoral artery. Okay, can see because they are just like on the same position. Just as the deep inguinal ring is on top, the femoral artery is down. That is also the same also in the female. So I've got something which is known as a cremasteric reflex. So the cremasteric reflex, so one is a reflex that can send impulses for arousal. So what happens is that look at the nerves which are going to the medial to the thigh. Okay. So in men, the cremasteric muscle and fascia form the middle or second covering of the spermatic cord. This muscle and its associated fascia are supplied by the genital branch of the genitofemoral nerve, that is L1 or L2. So contraction of this muscle can be stimulated by a reflex act. So what happens that just a gentle touch at and around the skin or the medial aspect or the spiral aspect of the thigh will be able to stimulate sensory fibers of the ilioinguinal nerve. These sensory fibers will be able to send the information to the spinal cord at L1, and then at this level the sensory fibers stimulate the motor fibers carried in the afferent branch of the genital nerve, and that will go back to the testes. So what is happening? So having ilioinguinal to the spinal cord and then back via the genital branch. Look at where the ilioinguinal is. So this is the femoral branch of the genitofemoral nerve, and then this is going to be the genital branch. You can see where the genital branch is. The genital branch is somewhere on the scrotum. And then you have got the ilioinguinal nerve. Now the ilioinguinal nerve is L1. The genitofemoral nerve is also L1. So what happens that the ilioinguinal nerve is more on the middle aspect. So if you touch a guy on this region, the impulses will be able to go up and it will go to L1. From L1 it reaches like the spermatic the it will reach the spinal cord, it will go to the brain, and then impulses will go down and then via the genital branch of the genitofemoral nerve it will go to the scrotum, and that will cause arousal like that. So that is what is known as the cremasteric reflex. So that is how it goes. Okay. It starts all the way from the from the skin. Actually, from the femoral branch of the genitofemoral nerve, a reflex can also go up and then it can come back to the genital branch of the genitofemoral nerve. This was the femoral branch. So in other words, whether you touch just somewhere, the skin just near here, impulse can go through the femoral branch or it can go through the ilioinguinal nerve like that. Okay, and then it will come back. You can have masses around the inguinal forming inguinal hernias and the femoral hernias. Inguinal hernias are going to appear through the superficial inguinal ring above the pubic tubercle and crest. The important thing is that inguinal areas will be above the pubic tubercle and pubic crest. They can also pass through or appear through the superficial inguinal hernia. But a femoral hernia will appear through the femoral canal. It doesn't pass through the inguinal canal, but femoral canal. And this is below and lateral to the pubic tubercle. Inguinal hernias can be direct or indirect. They're actually more in men than in women. Indirect hernias are the most common, and these ones occur because of some part of the processus vaginalis which remained open or patent. Okay, so it is also referred to as a congenital in origin. It's a problem in the origin. The protruding peritoneal sac. So if you have got any content of the peritoneum coming out of the abdomen, they are going to enter the inguinal canal. They'll enter the inguinal canal by passing through the deep inguinal ring. This is important. And an indirect hernia will pass through the deep inguinal ring just lateral to the inferior epigastric vessels, lateral to those vessels. So this is it. You can see where it is passing. It's actually passing laterally here. These are the inferior epigastric vessels. So it will be able to pass through the deep inguinal ring and then it will come and also pass through the superficial inguinal ring and then it will go to the testes. So this can contain like intestines. Imagine. Okay. Indirect, what you need to know is that it will pass through the deep inguinal ring. The direct inguinal hernia, unlike the indirect one, this one will originate lateral to the inferior epigastric arteries. Okay. Well, actually, I didn't mention this one well here. This one's supposed to be passing medial. Supposed to be passing medial to the epigastric vessels. And then this other one is passing, unlike the indirect inguinal hernia that originates laterally. Okay, indirect is lateral. This one is the one which is going to be medial. Okay, that was correct. This one is going to be medial. The indirect, we said it to pass lateral, and lateral was this side. This side. Here are the epigastric vessel, it passed this side. But for the direct one, it will pass medially. Okay, medially here. And one important thing is that it does not pass through the deep inguinal ring. This is one of the questions which were coming in last year's test. This one does not pass. The direct one will just go, think of it, direct one just goes direct to the superficial inguinal ring. It doesn't pass through the deep inguinal ring. Please take note of that. Femoral hernias, these ones will be able to move on the pass through the middle aspect of the anterior thigh like that, and then they'll be able to pass through the femoral canal. Okay. You also have umbilical hernias, which are more rare. They are mostly due to some congenital problems and mostly failure of the small bowels to retain. Because normally what happens is during the development of the midgut or the GIT, the intestines move and go through this is the umbilical cord, okay, by then cord like that. As development continues, these things are supposed to go back inside the abdomen. But if they fail to go back into the abdomen, they'll remain as an hernia like that. Okay. You also have incisional hernias. Incisional hernias occur through a defect in a scar. Imagine someone had an operation and then because there is a defect, it is weak, and then contents of the abdomen move out of the abdomen through that position. You also have what is known as sportsman or groin or sportsman's hernia. These ones are defined, they're going to be found where the legs meet the trunk near the midline, where the leg will meet the trunk. So just like somewhere where there's a junction there on the hip joint. Abdominal muscles of the trunk will be able to meet with the adductor muscles of the thigh at that point where they meet. Abdominal muscles meeting the adductor muscles. Okay. The medial end of the inguinal ligament where it is formed at that point, the pubic symphysis and the superficial inguinal ring occurs. So these hernias, they are known as sportsman hernias. That is because look at this, force during most athletic and sports activities. It is also, okay, let me just start here. It is also in and around this region where there is considerable translation of force. So it's known as sportsman hernia because when the sports people are running, they generate forces like from the hips somewhere there in that region for you to be able to push your leg forward to be able to run. That is why they are known by that name. Okay. So this is the groin. So that is